Golden notes. Henoch Schonlein purpura. It's an IgA-mediated small vessel vasculitis involving mainly the blood vessels of the skin, gastrointestinal tract, the kidneys, and the joints. 90% of cases of HSP occur in children aged between 2 and 10 years, but can occur in any age group. In children, Henoch Schonlein purpura is the most common cause of vasculitis affecting the kidneys, typically commoner in males. May follow an infection agent. It can present 1 to 3 days following infection of an IgA secreting mucous membrane, commonly following pharyngitis, but can occur following infection of the gastrointestinal tract, bladder, or breast. An important risk factor in adults, chronic alcohol intake, associated with Helicobacter pylori, hepatitis B, and malignancy. Features: Henoch Schonlein is characterized by the tetrad of purpura, abdominal pain, arthritis, renal involvement, hematuria, and proteinuria. Patients with proteinuria have a worse prognosis than patients with hematuria alone. Palpable purpuric rash with localized edema over buttocks and extensive surface of arms and legs due to a cutaneous vasculitis. Abdominal pain due to good vasculitis, which may be severe in some cases, leading to bloody diarrhea. Polyarthritis is a common symptom. Features of Iga Nephropathy may occur, for example, hematuria, renal failure. Schonlein nephritis becomes clinically manifest in only 20 to 30% of cases. It usually presents as macroscopic hematuria and proteinuria. Of those patients with renal involvement, as many as 10% may develop chronic renal failure and end-stage renal disease. However, fewer than 1% of all patients with HSP suffer this poor prognosis. Diagnosis: skin biopsy and immunofluorescence demonstrate leukocytoclastic vasculitis with IgA deposition, meaning lots of white blood cells in the skin around small blood vessels, which is pathognomic for Henoch Schonlein purpura. Immunofluorescence studies will reveal IgA deposits within blood vessel walls. Treatment: analgesia for arthralgia. Treatment of nephropathy is generally supportive. All patients with hypertension and proteinuria greater than 1 gram per day should be started on ACE inhibitor, which may control the blood pressure and proteinuria. Once the blood pressure has been controlled, patients should have a renal biopsy, and if this shows changes of a crescenting glomerulonephritis, then an immunosuppression regimen similar to that used in renal vasculitis should be started, probably with high-dose steroids in the first instance, and maybe plus cyclophosphamide. There is consistent evidence for the use of steroids and immunosuppressants. Management of Henoch Schonlein in adults often involves the use of immunomodulatory or immune-suppressive regimens, in contrast to children, where the majority of cases resolve spontaneously. Prognosis: usually excellent. Henoch Schonlein purpura is a self-limiting condition, especially in children without renal involvement. There is often a more complicated course in adults, and 50% of patients who present with renal involvement develop renal insufficiency. Around a third of patients have relapsed. Question from the previous exam asks, what is the most likely renal outcome in Henoch Schonlein purpura? It is full renal recovery. This was provided by the SSSM Study Smart Series for MRCP, your easy way to easy pass. Don't forget to follow us on Facebook, Telegram, and YouTube channel. Thank you very much.